Suppose you are intubating and suddenly you have an unexpected difficulty. You're not able to view the cords, you're not able to intubate. Anything special we have to do? You have to transit through the algorithm. This is your regular difficult airway algorithm. You have to transit through that. You have to minimize your attempts as much as possible. At each stage, please declare difficulty or failure to the team. And sometimes a second generation supraglottic airway can be used. And if all things fails, you have to go for a front of neck airway management technique like a scalpel bougie technique to place a tube. So that is also very important. So you have to transit through the algorithm very, very fast. See, first and foremost, quickly you have to do the intubation, because every second, every minute you stay there, there is a potential hazard to the healthcare professional. At the same time, there will be occasions when there will be difficulty to be faced. That is where a senior person at that particular junction knows exactly what to do. He has traveled through these situations many times in his life. Simple adjustments, simple things, he will be able to get the job done much better than a junior person at that time. So there are no egos, nothing here. You have to get the tube in as early as possible. So be well prepared. So difficult airways can be reduced to the bare minimum. And if at all a really difficult airway occurs, which even a senior anesthetist is not able to bypass, then automatically you're going to go for your front of neck airway technique. Your scalpel bougie technique will be very, very, very useful. Okay. So this is the algorithm, how you're going to transit when there is a difficult intubation. Cannot intubate. I'm not able to intubate, sir. I'm not able to oxygenate, sir. What do I do? You go for your scalpel cricothyroidotomy set. Okay. Next, what do I do post-intubation? So there are some practical points which I'll give you here. The moment you intubate, you clamp the endotracheal tube. Okay. Now you're attaching the viral filter, etc., and you are attaching the EtCO2. You're attaching to the ventilator. Now you are unclamping. After that, you have fixed the tube, etc., etc., done. So if the patient is stable, just keep the ventilator at 100% FiO2 and walk out of the room. Except one staff. All the others just walk out of the room. And once you come out of the room, just wait for some time. Keep monitor. The staff will be monitoring, etc. Just keep at 100% FiO2. BP is stable, pulse is stable, adequate fluid is going. Just keep a backup vasopressor also to see to that there is no BP fall, etc. Just step out of the room, take some 10 to 20 minutes, and then if the patient is still stable, you just ask them to clean the floor, etc. Ask a housekeeper, a housekeeping staff wearing PPE. So everything is clean. After that, after 20 minutes, you can again, after 20 minutes, what I meant is after 20 minutes. And after that, the cleaning, etc. done, then you go in, etc. Now you start recruiting the patient on the ventilator. You start operating the PEEP, etc. and try to come down on the FiO2 after some time. So this will give some time for the aerosol, whatever was generated, to be dispersed, diluted, and it will be taken out through the negative pressure room. And even Ryle's tube, etc. now you can put. It is a closed circuit. Endotracheal tube, filter, ventilator, it is completely closed. No escape of gas, very, very safe. Now you can go ahead and place a Ryle's tube also. So that is very, very important. So this is one thing which I wanted to understand. But sometimes some patients post-intubation, they will crash. So those patients, definitely you have to be there and take control and try to save the patient. That is a different story. But wherever an opportunity presents to you, at that time, this is how you should handle the situation. So cuff pressure monitoring is very, very crucial. Every shift, every time, the technician and the staff should monitor the cuff pressure. Keep it just 5 centimeters above the maximum inspiratory pressure which you are giving. And monitor and record the tracheal tube depth. The tracheal tube might slip in. So just see to that you are able to monitoring that, having a close monitor on that. Closed tracheal suction. At no point, even if the patient is becoming hypoxemic, don't go for open suction. There is no role for open suction in a COVID ICU. You have to only do closed tracheal suction. Suddenly, sometimes what will happen is sudden cuff leak will be there. So if a cuff leak is there, that can definitely result in lot of aerosol generation. So when there is a cuff leak, the staff nurse will be there. If suppose the intensivist is there within the complex wearing a PPE, he will come immediately and do the remove the tube and put another tube. That is a different scenario. But suppose if a doctor is there who is not so well versed in intubation, at the same time you need some help from an anesthetist to come in wearing a PPE, you need some time. So during that time, there could be a lot of aerosol generation within the room. So to prevent that, pack the oropharynx with a pack, okay, ENT pack. Like that, you can use that. You can pack the oropharynx. So till the anesthetist comes to the place. And airway interventions. So many of these patients, you see, once they are intubated, they might be proceeding, they might be having ARDS and all. Sometimes we do prone them. And sometimes we may be shifting them for CT scans, etc. and all. So all the time, the continuity of the circuit will be affected. So those are called as airway interventions. So when there is an airway intervention about to happen, you ensure adequate sedation and paralysis so that the patient doesn't cough, doesn't bring out any more secretions out. You pause the ventilator so that both the ventilation and gas flow will stop. Use the tracheal clamp. You clamp the tracheal tube. So each and every point is important. Ensure adequate sedation. Consider administering neuromuscular block. You pause the ventilator so that both ventilation and gas flow stops. Clamp the tracheal tube. You separate the circuit with the HME still attached to the patient. Very important. Separate the circuit with HME still attached to the patient, and you have to reverse this procedure after reconnection. So this is how you have to go ahead. And when you're transiting them down for a CT scan, better not to ventilate them with hand. Have a portable ventilator in place so that you are not very close to that, and you're not in a position where you're ventilating with the vein circuit near your face. That's what I want you to understand. So these are things which you should remember. But practically, many patients where we have ventilated, we have found out taking them down for a CT, etc. It's not so easy. It's very cumbersome, and you always have to weigh the risk benefit for the patient as well as the risk which it might entail for the healthcare professional. So try to be a little bit puristic in this sense and just do it when there is a real need. Proning, definitely you may have to do in some patients. So for those patients, you have to be very, very careful. Okay. So now coming to accidental disconnections, accidental extubations, tracheostomy. Sometimes it may disconnect. Sometimes it may be accidentally there might be an extubation. Don't panic. As I told you, there is no emergency in COVID-19. You have to, the intubator, whoever is going to come and help you, has to come in with the full PPE on, and then only you have to be doing it. Actively humidified and humidified wet circuits have to be avoided. There will be a nidus where the virus can be deposited, etc. So this can result in certain levels of infection. And so the most important thing, tracheostomy. When do I do tracheostomy on this patient? This question is still there. So most of the patients, remember, tracheostomy is done. You ventilate them for at least 2 weeks. And ideally, tracheostomy is done after 2 weeks. And by that time, they might become COVID negative. That's what I want you to understand. You will be serially checking their COVID test. They'll be positive initially. So as day 12, day 13, sometimes some patients might become COVID negative. So to be very safe for the healthcare professional and the ENT surgeon and the intensivist who are going to do the procedure, it is better if we do that kind of tracheostomy-like procedure when the patient is having at least 2 COVID negative tests. So till that time, you can wait. There have been reports in abroad where they even waited up to 28 days, 26 days, and after the tracheostomy has been done. Okay, so you can wait on that. But remember, tracheostomy can also produce a lot of aerosols.